So, all right, can you all see that okay? Awesome.
I thought today we would review just some case discussions on how to prevent and treat hypoglycemia. In the past, I kind of just reviewed the ADA guidelines, and I thought that got a little bit boring. So I tried to just add in some cases so we can really have more of a discussion. If you guys like this format and it's better, let me know, and I can try to incorporate more cases as we go along, as opposed to just kind of reading off the guidelines, because I even put myself to sleep doing that. So we can go on to the next slide. Our objectives will be to identify factors that contribute to hypoglycemia in patients with diabetes, recognize impaired awareness of hypoglycemia in our patients with diabetes, develop treatment regimens that minimize the risk of hypoglycemia, and discuss impaired awareness and how to help patients regain awareness of hypoglycemia. Next slide, please. So hypoglycemia was recognized right after the discovery of insulin in the 1920s. It was first discovered by James Collip when he was working on purifying insulin and giving it to rabbits in the lab, and noting that they had shakes and seizures from insulin administration. And it was experienced frequently by one of the very first patients who was on insulin therapy. Her name was Elizabeth Hughes, over there to the right, who had multiple insulin injections throughout her long life. And it was advised that she carry molasses kisses with her to treat hypoglycemia. And also, they had these historic cards that I found from the Historic Society that states if a patient did have shakes or seizures, that card said, I am not a diabetic, I am a diabetic, and I am not intoxicated. And the doctor's contact information, which I thought was an interesting piece of history. Next slide, please. So hypoglycemia is the major limiting factor in the glycemic management of both type 1 and type 2 diabetes. The way that it's classified, this comes out of the American Diabetes Association guidelines. So you can see we have 3 different levels. The first level is a glucose less than 70 and greater than 54. Level 2 would be a glucose less than 54. And level 3 is a very severe event characterized by altered mental or physical status requiring assistance for treatment of hypoglycemia. Next slide, please. So why is less than 70 considered a threshold for clinically important hypoglycemia that we tell patients with diabetes to treat? So a blood glucose of 70 has been recognized as the threshold for neuroendocrine responses for a falling glucose in patients that don't have diabetes. Many patients with diabetes demonstrate impaired counter-regulatory responses to hypoglycemia and or experience hypoglycemia unawareness. So that's the reason for the threshold of less than 70. When a patient has level 2 hypoglycemia, which is less than 54, neuroglycopenic symptoms should occur. So mental status changes, confusion. Hypoglycemic unawareness is one of the things that we're most concerned about in our diabetic patients in clinic. So this is a blood sugar less than 54 when patients do not have the adrenal or neuroglycopenic symptoms kick in. You want to investigate and review or change the medical regimen, consider use of technology like continuous glucose monitors to help prevent this, and then behavioral interventions as well. And we'll talk about this a little bit more as we go through our cases. Next slide, please. So some of the symptoms of hypoglycemia, they include, but are not limited to, shakiness, irritability, confusion, tachycardia, and hunger. It can progress to a loss of consciousness, seizure, coma, or death if left untreated. Next slide, please. So case 1, this is Lola Sugars. She is an 82-year-old female with a 40-year history of type 2 diabetes. She's brought in by her husband with concerns of hypoglycemia. Her husband reports finding her unresponsive on the couch, EMS was called and her sugar was reported to be 43. Lola only recalls sitting down on the couch that afternoon to watch her favorite soap opera around 10 a.m. Next slide, please. Her medical history includes coronary artery disease with stents. Her meds include clopidogrel, Crestor, lisinopril, glyburide, 5 milligrams twice a day, metformin, 1,000 twice a day, sitagliptin, 100 daily. She typically eats breakfast around 6 a.m., eats out at a restaurant with her husband for lunch most days of the week, and leftovers at home for dinner. She's snacking, in between meals regularly. Her A1C is around 7.5. Next slide, please. She brings her blood glucose and diet trends with her. So I have to enlarge this so I can actually see. So her blood sugars around 5 a.m. were 100 on her first day. She ate a donut for breakfast around 3 p.m., eats a cheeseburger from McDonald's and some apple pie. 5 p.m. checks her sugar. It's around 180. 10 p.m. checks again, 140. The next day wakes up, checks sugar around 90 in the morning, eats some fruit. Around noon, blood glucose is 89, treats herself for a low, doesn't really feel well with blood sugar of 89. Around 5:30, checks her sugar again, 200 at that time. Around bedtime, checks again, around 159. She can't sleep, vacuums her house, goes down to a blood sugar of 75, so eats 2 scones. Next morning, wakes up, blood sugar's around 82, eats a croissant. Around 2 p.m., she exercised and felt sick, didn't check her blood sugars, ate 3 cookies and felt better. Around 6 p.m., feels ill and shaky, eats 3 more cookies. 11 p.m., goes to bed with a blood sugar of 200. Next day, 6:30 a.m., wakes up with a sugar of 84. Around noon, she walks around the block and notes her sugar's down to 72, eats chips with peanut butter and jelly to bring it up. Around 6 p.m., her sugar's around 126, and then 9 p.m. goes to bed with a sugar of 80. So next slide. So what can we do to help this patient? We often get these blood glucoses, the logs with their blood sugar checks, what they're eating, kind of what their exercise is. If we're lucky, we get them. And not often do we get, routine checks at breakfast, lunch, and dinner, or exactly what the patient is eating. But really any information that we can gain from the patient is very helpful. So medication strategies, what can we do to discuss regimen changes? Do you guys all think that she needs glyburide? Remember, she's in her 80s. Her A1C was around 7.5. Do you think that she needs glyburide? You can chat in, you can unmute yourself. Anybody have thoughts on that?
I'll help monitor the chat for you as well if anything comes through.
Okay, so I don't think she needs glyburide at this time. Glyburide is sulfonylurea. So I see that the endocrine conference room is chatting in. Awesome. Yeah, I don't really recommend glyburide. It can predispose to hypoglycemia. It can cause hunger and weight gain. And her A1C is in target for her age. So I think that we always need to be mindful of what our A1C target is. And in an elderly adult, which elderly is classified as greater than 65 years old per the ADA geriatric diabetes guideline. And so for elderly adults, we want to consider an A1C of 7 to 7.5 if they're, more healthy, mobile. And then if they're not as healthy and have multiple comorbidities, adjusting that A1C target to more of 7.5 to 8 or potentially higher if the patient is more sickly. So we need to really know what our target is to know how aggressively we need to treat. So in an 80-year-old with what sounds to be quite a bit of symptoms and low blood sugars running in the 80s and sometimes lower, she had an event on the couch, I would stop the glyburide and consider loosening up her regimen and allowing her A1C to rise even higher. Food strategies can be things like a referral to a dietitian to eat more consistently. You see that her timing and portion control is really off. So eating erratically throughout the day and eating, a scone or a muffin here or there, to try to get on a habitual pattern of eating breakfast, lunch, and dinner with snacks in between. And if they're snacking, trying to eat less than 15 carbs a grams with those snacks is ideal. Dietitians and nutritionists certainly help us in that department. And then avoiding high carb snacks. So again, 3 cookies or 3 scones is going to be a tremendous amount of carbohydrate. So avoiding that really high carbohydrate snack. Activity strategies, so checking blood sugars before and after exercise, and consider taking a snack if blood sugar was low, if she's going out walking, or even things like vacuuming the house like she was doing are considered sometimes moderate to heavier activity for elderly patients. So making sure that can be an exercise, and checking blood sugar beforehand would be helpful. But yeah, in this case, I would stop the sulfonylurea, and may even stop the DPP-4 as well, and just kind of follow her A1C over time every 3 to 6 months. And if it significantly rises, consider, adding back maybe the DPP-4, but definitely allowing her A1C and her blood sugars to rise is what I would do. I put the link for the adult geriatric guideline from the ADA in there if anybody is interested. Next slide, please. This is case 2. This is Henry Hypodriver. He's a 61-year-old male. He's had type 1 since he was 21 years old, lost his driver's license due to a hypoglycemic event while driving. He's had a long history of frequent hypoglycemia. Next slide, please. His past medical history, he's got triopathy, really. Retinopathy, has monthly or every 3-month eye injections, hypertension, peripheral neuropathy, CKD. His meds include Semglee, 18 units nightly. That's a long-acting insulin. He takes Lispro, 1 unit for every 10 grams of carbs. And then he takes a supplemental scale of insulin. He adds on 1 unit for every 50 greater than 150. Lisinopril, atorvastatin, and aspirin. His diabetes has been very poorly controlled. His A1C ranges from 8.5 to 10% over the past 3 years. Next slide, please. So he typically skips breakfast and eats lunch at noon and dinner around 7 p.m. He does not snack. He's an avid dancer. He likes to bike. He lost his license when picking up his girlfriend around 11:30 in the morning when he became confused without warning and drove into a pole on the side of the road. So next slide, please. I just wanted to add in some pictures here. This is some diabetes technology examples for you. And I put 2 different types of continuous glucose monitor reports on here. So on the left, you can see a Libre report. On the right is what a Dexcom report would look like. And in someone who's having significant low blood sugars, you can see on the Libre report that I'm sorry if this is really small, but on the Libre report, you can see the low and the very low in the red. And we really try to aim for a percentage of less than 4% below 70 and less than 1% below 54 for our continuous glucose monitor guidelines. And so when I see the amount of lows, if someone's having 10% lows on their continuous glucose monitor, and obviously if they're getting into car accidents from low blood sugars, it's one of the most concerning, scary things for an endocrinologist and for a patient. And so we really need to make quick adjustments to make sure that stops. On the Dexcom on the right here, you can kind of see the lows in the red portions that are occurring overnight. On both of those images, it's from 12 a.m. to 12 p.m. throughout the x-axis there. And if you want more examples on the Dexcom and Libre website, they have some more examples of how to read a Dexcom or a continuous glucose monitor or Libre, if you're interested in more on that as well. So technology is really helpful, and looking for hypoglycemia, and also having these instruments alarm for low blood sugars so that the patient can be aware of it and either wake up and treat it or treat it before it goes significantly low, especially if the patient has hypoglycemic unawareness and they don't feel any symptoms. Next slide, please. What can we do to help this patient? So food-related strategies, similar to our other patient, referring to a diabetic education center to assess how he's counting his carbohydrates. Since he is on an insulin to carbohydrate regimen, it's really important to know exactly how our patients are counting carbs, because it is one of the most challenging things to do for diabetic patients, is to accurately count carbs. There are apps that can help. There are brochures and strategies that we can help them with so that the carb count is accurate. Because in a patient like this, if they're getting too much insulin and underestimating their carbohydrates, that may be in fact contributing to low blood sugars. So insulin dosing, it's always important to ask how much your patient is taking, how they're taking it in relation to their meal and their administration sites. So insulin is best absorbed through fat. So sometimes if they're alternating their site, like giving it into their arm, into the muscular part of their arm, they may not absorb it as well. And then if they rotate to their stomach and are injecting into their stomach, they may absorb it more efficiently. So asking really how they're taking their insulin. And then how the patient is treating their lows and making sure that they're appropriately treating low blood sugars with the rule of 15s. So the rule of 15s, which I have at the end in more depth, but just to kind of go over that, that's if a patient does have a low blood sugar less than 70, recommending that they ingest 15 grams of carbs to treat themselves and then rechecking their blood sugar 15 minutes later. If their sugar isn't greater than 70, to then attempt to retreat their blood sugar. And then advise them to prepare a hypoglycemia treatment kit. So glucose tablets are really easy to dose properly, and asking them to make sure that they're getting at least 15 grams in their glucose tablets. Some of the tablets have 4 or 5 grams. So it's important to let them know they may need to take 3 glucose tablets. I have a lot of patients that come in and say, well, I took, 1 glucose tablet to treat myself, and that's really underdosing them. So the rule of 15s is really important to educate our patients on. And then medication strategies. So does he have hypoglycemia unawareness, and how do we really restore awareness for this patient so he doesn't have another accident again? And that typically it's recommended that we reduce or eliminate hypoglycemia for a 2 to 3 week period. And that in itself is supposed to help the patient become more aware, so that if they do have low, they have those symptoms of lows like sweating, shaking, so that they can treat themselves appropriately. So can we stop insulin in a patient with type 1 diabetes? Should we stop insulin in this patient? Definitely not. Any type 1 diabetic patient always needs basal insulin on board. So stopping basal is not an option, but we can certainly reduce insulin. And again, we can talk about carb counting and reducing insulin if he's in fact getting too much insulin, maybe with his dinner, or erratically kind of counting his carbs. I often get the question, should the patient use an insulin pump now because they're having hypoglycemia unawareness and accidents? Would a pump be the best thing for him? And my answer to that is always, if the pump is the best thing for the patient. Pumps require a lot of interaction and the use of technology. So not every patient wants that. So we can certainly continue insulin injections. And if the patient is open to getting a continuous glucose monitor, that can certainly reduce the risk of severe hypoglycemia in the future. So if they're not open to a pump, then I at least kind of ask them if they would be open to a continuous glucose monitor, which is what I showed you on the previous screen. So activity-related strategies, we can ask the patient to check their blood glucose before, during, or after exercise, because he is an avid exerciser, and then continuing glucose monitoring. or a CGM is an excellent tool to help. Next slide, please. Additional considerations. So again, I wanted to bring up type 1 diabetes. So in a type 1 diabetic patient, if they are having severe lows, just consider checking a cortisol level, especially if they have other signs of adrenal insufficiency. So cachectic, losing weight, nausea, vomiting, anorexia, if they have irregularities in their sodium and potassium, and they look as though they may be adrenally insufficient, that's something to consider. Celiac disease, so understanding that autoimmune diseases all can run in clusters. Adrenal insufficiency, celiac, type 1 diabetes. So consider screening the patient for celiac. In the diabetes guidelines from the American Diabetes Association, they do recommend screening for celiac. So asking patients about symptoms and screening with a celiac panel if they do have symptoms every 3 to 5 years. And then considering drugs, alcohol, or other supplements that may lend to hypoglycemia. Also, I just wanted to make mention of a GFR, because as the GFR declines in any patient, whether they're type 1 or type 2, insulin may need to be reduced as it's metabolized through the kidneys, so it may hang around longer in patients who do have CKD. Oops. Are you still there? Sorry about that.
That's okay. Yes, we can still hear and see you. Can
Okay.
you see the slides okay? I can stop
Yep.
sharing. Okay.
Yeah, it just cut out for a second there because I was getting an incoming call. Sorry about that. So we could go on to the next slide, please. So I just posted this because the rules are different from state to state, but the rules for West Virginia and driving are that, if you do have coma, seizure, loss of consciousness, that it does require that you check in with your physician that's treating diabetes, and that you have, full physical exam and make sure that it's appropriate for you to be able to return to driving a car. Next slide, please. So this is a case 3, and I'm going to stop for a second and just ask, does anybody have any questions or comments about the first 2 cases before we go on? No. Okay. So this is case 3. This is Sam, low swimmer. He's a 42-year-old male, type 1 for about 35 years now. His A1C is 6.9%. He wants help in dealing with hyperglycemia that happens after swimming, pretty much immediately after swimming. He swims about 3 times a week. He checks blood sugar prior to dinner and typically takes 3 units of Lispro with meals. His blood sugar before dinner is around 100 and before swimming around 100. Then goes to about 160s 1 to 2 hours after swimming, and that's concerning to him. He's taking several small bolus of insulin for that sugar of 160, then finds himself low overnight into the 40s. He reports a history of nocturnal seizures, which happen without any warning, never wakes up with sweats. His wife just finds him having a seizure. Next slide, please. So this would be an example of what his continuous glucose monitor would look like, and each color is represented as a different day of the week. So you can see here, blood sugar is pretty much stable on our x-axis from about 12 a.m. up until about 3 p.m. He has his swimming exercise, and then he goes up around 150 to 160. Following that, his blood sugars after swimming start to decline around 7 to 8 p.m. at night, and he falls overnight. His medications include glargine 7 units twice a day. He insulin to carb counts 1 unit for every 15 grams of carbs. Lives alone now. He has no diabetes complications to date. Next slide, please. So how can we help this patient? If we're talking about food-related strategies, we want to be mindful of eating too many carbs prior to exercising, as the exercise may not be enough to lower the blood glucose in range. Using medication-related strategies, so can consider reducing his basal insulin overnight or lowering his basal rate if the patient were to be on an insulin pump. We can certainly set temporary basal rates if a patient were to exercise 3 times a week. So we just would reduce the basal rate those 3 days of the week. We want to ask him to avoid stacking insulin. So stacking insulin means that small microbolus of insulin, they just stack on top of each other and can cause a very low blood sugar. So we want to allow the active insulin that's circulating through his body, the short-acting insulin, to work for 4 to 6 hours before we ask him to correct a blood sugar. And that's called stacking insulin, when we use too much in too short of a period of time that causes hypoglycemia. Allow the blood glucose target to rise while we address hypoglycemia unawareness. So I touched on this a little bit earlier. In patients that have hypoglycemia unawareness, the best treatment is to absolutely avoid hypoglycemia for a 2-week period to allow the symptoms of hypoglycemia to come back to the patient so that they can be aware if their sugar is dropping and to appropriately treat it. And then address the goals. So his A1C is 6.9%. He is having severe low blood sugars. So in this patient, allowing his A1C to rise slightly is fine. Allowing his blood sugar to be 160 after exercise is fine. That is a normal blood sugar. And so teaching our patients that having low blood sugars, that are too low is also uncontrolled diabetes. And that's also very scary. We aren't aiming for an A1C of 4%. We're aiming for an A1C. The magic number is typically less than 7% in this patient's age, but only if you can achieve that without severe hypoglycemia. So in patients that do have hypoglycemia, allowing that A1C to rise temporarily and the blood sugars to rise until the awareness returns is really important. Some activity strategies. So some types of exercise, such as heavy lifting, sprinting, competitive sports, they can cause your stress hormones to be released and they can cause hyperglycemia. Other exercises like aerobic exercises or workouts may not cause that catecholamine response and may in fact cause low blood sugars. So it really depends patient to patient on how their blood sugars fluctuate around exercise. So it's really asking your patient what type of exercise they do and how it's affecting their blood sugars. So then you can really come up with a plan for their insulin therapy that targets their specific workout. And those are some strategies that are kind of helpful for this patient. Next slide, please. So I'd like to just review the treatment of hypoglycemia. We talked about treating for anything less than 70. We talked about the rule of 15. Again, that's just 15 grams of carbs, 15 minutes, rechecking your blood sugar and treating again if your sugar is less than 70, not operating any heavy equipment or driving if you're having low blood sugars. Hypoglycemia is reversed by either rapid acting glucose or glucagon. Glucagon is typically reserved for treatment of hypoglycemia in people who are not able to eat anything by mouth. There are newer glucagon kits that are ready to inject, and also intranasal glucagon is also now available. I would just encourage you to check expiration dates on those because some people keep their kits around for years because they can be expensive. If it is expired though, making sure that they're checking their dates and getting an updated script. And next slide, please. I just wanted to put some pictures of the newer things that are available. Glucagon used to be kind of what we prescribed historically, but just to kind of make you aware of newer things, there's Baqsimi nasal powder, and there's also the Gvoke hypoglycemia pen that comes pre-mixed already. And then the glucose tablets are really nice because, like I said, that enables your patient not to really overshoot or overtreat. If they're treating a low blood sugar, you can tell them, take your 15 grams of carbs, and that way that they're not overtreating themselves and not drinking a Mountain Dew and going up to a sugar of maybe 400. So that's a simple way to treat as well if they're able to take something by mouth. Next slide, please. So one other thing that I wanted to mention, which was in my slide, was hypoglycemia kits. And I tell people to carry their kit with them all the time, which that may include the Gvoke pen, the glucose tablets, a backup meter, and supplies if they should need them. And that's all I have. Any questions?
Thank you so much, Dr. Giordano. I really love how you incorporated those cases as well. It's very helpful.
Yeah, I'm gonna try a new style, just more interaction instead of reading guidelines, because like I said, I put myself to sleep. So I'm glad it was helpful.
Absolutely. No, both ways honestly are so helpful and informative, but I like this new format that you incorporated. So thank you. And we got a chat as well from the conference room. Thanking you.
Thanks, everyone.
Any questions from the conference room? You're welcome to chat in, or comments, not necessarily questions. None here. Okay, no worries. And we're recording this as well, so we'll be sure to post it on our YouTube. So the participants who are able to join will be able to watch it. And sometimes we do get questions via email as well. So if we get any of those through, I'll send them your way, Dr. G.
Sounds good. Thank you, Mitra.
Thank you so much. We really appreciate you. The only announcement I have is our next session is August 10th, and Renee Schwartfager will be presenting on hyperparathyroidism. So keep an eye out for that reminder, and I hope you all have a wonderful afternoon. Thank you again,
everyone.
Dr.
Thank you.
Thank you.